Thank you. You know, it's not a GCU commercial, but it'll do. I'm sure you guys see those around here. Hi, I'm Brandon Warner. I'm excited to be here and kind of share my passion with you on electrical stimulation and just modalities in general. You know, I know it's not everybody is like, what's a run down the road to go to modalities lecture when it comes to NATA, but you know, there's a lot of really great things that we do as athletic trainers, especially when it comes to treatment and rehab. So first, I'd like to thank Spats for allowing me to speak here, as well as my wife, because behind every good man's a good woman, right? And tomorrow is my 6-year wedding anniversary, and I'm not there. So, yes, she's not here either, so don't think she's speaking tomorrow, so at a different location. So we both kind of took this year off. You guys are like, wow, this guy's weird. So, you know, I also want to thank Grand Canyon University for allowing me to come here and present to you guys. Kind of one of my passions is what I teach in the athletic training program, so I'm pretty excited to be here. Disclosures, I don't really have any. There's nothing to report. There's no financial implications or anything I'm trying to sell to you today. Okay. So kind of an overview where we're going today is we're going to learn, I'm going to kind of list the learning objectives. We're going to talk about evidence-based practice as it relates to therapeutic modalities. Because we learn about evidence-based practice, we think about it a lot when it comes to concussions, when it comes to pretty much everything we do, but the clinicians are sometimes some of the most important parts of evidence-based practice. I'm going to show you why. Okay, we're going to talk a little bit introduction. I have a poll everywhere, if you're familiar with that. I'm going to do a little bit of research right now at this presentation to kind of see, you know, some knowledge, but also your guys' interest in what you do in the clinic, because it helps kind of shape. Sometimes we come up here and talk and we don't know the population that we're speaking to. I'll give you my PICO question. We're going to talk about eSTEM, its foundations, its application guidelines, evidence-based practice, and kind of end with some concluding statements and best practices. So learning objectives for today, the conclusion. I'm hoping everybody can describe the importance of EBP in therapeutic modalities. Select the appropriate type of eSTEM for acute pain management, also post-operative pain. Okay. I also design evidence-based decisions for optimal pain relief using electrical stimulation and modify treatment parameters. I know as a program director and dealing with about 54 different preceptors in our athletic training education program, there is a wide variety of individuals. That fourth bullet point, really we have to go out there and educate those athletic trainers as well and have this continuing education with them, because there is a lot of things that are coming out there for modalities. Even just going out in the trade show out there that you guys have, there's quite a few things that are out there on the market that have different and variety parameters. So educating all of you today kind of what the evidence is showing for optimal parameters. So what is evidence-based practice? I think everybody's been to enough of these to understand that. But today, I want to kind of discuss evidence-based practice versus practice-based medicine. Because there is a huge emphasis on evidence, but you as the clinician, you as the front line, are a lot of times that beginning for the researchers to start investigating what best practices really are. So there's internal evidence, and that's a lot of what you do as clinicians. It's clinical experience. It's experience with patterns and outcomes. I mean, I still practice clinically, but that's one thing I like to sit out there, like at the BMX track or at a venue, and kind of look for patterns, things that I can explain via science. Okay, and even the interaction and outcomes. There's a lot of times where preceptors come up to me and say, "Hey, Brian, I have a research idea. I've been noticing this using this modality or this intervention. What do you think?" You know, so I want you guys to know that you are the front line with your knowledge and things that you do and get to witness. It helps us build the next step, the external evidence, and that's derived from case studies. In fact, if you look at that pyramid, which you'll see here in a second, the foundation is a lot of those case studies, case series, those patterns that inform randomized controls. Okay? Then a meta-analysis and our systematic reviews being the top level of evidence. And a lot of these encompass epidemiology, and you know the rest, etiology, diagnosis, prognosis. So again, here is where a lot of clinicians out there lie, in that evidence-based practice is the internal side, but you kind of go both ways. We ask our preceptors when we do clinical research, we reach out to local high schools and we let them participate in the process. So again, here's that pyramid. And here's kind of where we're looking. And above is our level 1 evidence. A lot of the reviews we look at today, a lot of this information does derive from the lower part of this pyramid, more specifically the randomized control trials. But what builds us that next step to get to that point is some of those other types of evidence. So, to kind of further define it, we've also seen this in multiple models, but looking at the best evidence available, kind of the patient's unique values of situations, plus your clinical expertise actually does add up into evidence base. There is a lot of knowledge out there and a lot of things that we do. Okay, I was at a presentation, and one of my old mentors, Dr. Saliba out of Virginia, so she listed a statistic saying that it would take an athletic trainer to read 11 articles per day for their career to stay current in athletic training education. Who has time for that? Right, we just learned about nutrition. We learned about even a prevention program. We're kind of filling all these things here, and 11 articles a day to stay current. Okay? So a lot of times we do rely on that clinical expertise and even bring in those patient values. So this is probably a familiar picture for a lot of people out here. And I would ask you, is that injury real or fake? I don't know. You wouldn't be able to tell. They're good actors. So when we think of patient preference, that's not the athlete who comes in and says, I need electrical stimulation. That's the only thing that works. Okay, what we're looking at here is previous experience. Okay, even some of their expectations. So when it comes to modalities, if we don't explain and kind of sell that treatment or even tell them a good basic informed consent, it may not work to begin with. I remember witnessing an athletic trainer explain to a patient that I'm going to use laser on you. And the patient asked, how does it work? And they said, I don't know, it's magic. Hey guys, you guys ever see that? Or maybe even that topical gel. I'm going to crush up some aspirin, put it in some ultrasound gel, and boom, we have ourselves a topical analgesic. It doesn't work that way, people. Maybe your athlete's placebo effect will kick in, but it's part of how we present this as well. And if that patient comes in thinking what you're going to do has no shot at working, it's probably going to be a poor outcome or a worse outcome because you're going to have to try to convince them why it works. And I think we've all seen that in our clinical practice. I remember my first week on the job as a certified athletic trainer, and I saw it multiple times. Well, this past athletic trainer did this. So they have an expectation. Okay, so part of modalities research, when we look at what's all out there, and you're going to see here in a few slides why things in modalities sometimes aren't what they seem, patients' expectations sometimes are a little off. Okay? And what are your perceived barriers? Believe it or not, there was a study in 2013 that polled athletic trainers and other providers, and most people said time was the #1 reported barrier to implementing their research. Availability of different people to mentor them. In fact, there's a presentation during this conference looking at mentorship, mentoring the athletic training profession. I tell our students that's something that you should really look into even once you're a certified athletic trainer, is mentor of somebody who you respect. Other ones are access to resources and skills and attributes. Now, one that's not up there that I think is a perceived barrier is new modalities and interventions. I think of this domain sometimes as it's almost like the fad diets, right? A couple years ago, you have this modality, that one, where diathermy was coming back in 2000 and never really kind of emerged. You can kind of see one out there right now. Okay? Because preference and change happens. Just think of 2008 Summer Olympics. I guarantee you someone out here can tell me what athletic training product made mainstream in 2008. Kinesio tape. Okay? Everybody wanted to wear it because it looked really cool on beach volleyball. Okay? And in Olympics, 2016, cupping. Some of us out here was like the hipster who burned their tongue. They were doing it before it was cool. I did cupping in 2012, and no one knew what it was. It's like, would you lose a battle to an octopus? But now, in 2016, everybody wants cupping. Every clinician, even doctors, like, try cupping. Do you see how mainstream some of these interventions can be? And guess what? It takes 17 years at times for best evidence to make practice. And if we've had a shift from the best thing to cure everything is kinesiotape to everybody must have cupping in less than 10 years, do you see how sometimes therapeutic modalities and some of our conventional modalities can go to the wayside? I mean, that's a problem right there, is seeing all these different bad things. And by the time we actually start seeing the evidence from these interventions, we're on to the next biggest and best thing. So, I mean, that's kind of that landscape that we're looking at when it comes to therapeutic modalities and some of our other even prevention methods. So let's kind of dive in a little bit more. So, pain. So looking at modalities, one of the biggest things that you see in your clinic is pain, right? You don't see an athlete come in and say, I have an increased girth measurement of 1 centimeter. They're probably saying, my ankle hurts. Okay, I can't run because this hurts. And in fact, post-operative pain is pretty common. I was reading a study, one of them was published in 2004, one was in 2013, that showed that about 60% of injuries in the high school level were in and around the knee, and almost 50% of those are ACL tears. We just had a presentation on preventing injuries in lower extremity, and it makes sense. So what do you think is a problem? Post-operative pain, and in fact, it's managed poorly worldwide. Okay? And even evidence suggests that people who have surgery do not get adequate pain relief. Less than half of them get adequate pain relief. Have you had that patient who went in for surgery, that needed that back surgery or knee, and are still having residual problems months after? I know a lot of patients that do that, and we try everything we can to make it so we can mitigate that pain. Because inherently in sports medicine, there is a risk of injury. I mean, I hope that's not new information for people here, but we have an inherent risk of injury. And right now, what we're saying is pain management can be poor. Okay? And adequate pain management is best for outcomes. Happy patients heal, right? And pain can not only have just a physical manifestation, but it can have a mental and emotional response as well. And that's where we can start diving into what you're going to talk about tomorrow at another discussion, is psychological first aid, is you start seeing these manifestations that are more than just a physical presence. So it's pretty exciting to talk about that. So what we're going to do is we're going to look at some stats. But instead of me sitting here reading and kind of telling you what I found, we're going to see what you know. If anyone's done this before, it's quite a fun little activity. It's called Poll Everywhere. I use it in the classroom to quiz students live action. So yes, you're taking a quiz right now. There may be right or wrong answers, but you're not going to get downgraded for it. There's nothing you're getting out of it. Maybe, not in particular. So you're going to go to this website, pollev.com/bwarn646. And here's kind of the ground rules that we're going to play with this game. When you first go there, it's going to say Brandon hasn't uploaded anything yet. You get one response. Don't click multiple times. I even locked it so you can't change your answer. So don't just click the button really fast. And also, working BMX, I've learned a really cool term for people who kind of like wait to the last minute or just like go really slow then speed up at the end. They're called sandbaggers. We don't want any of those. So try to answer. You get a minute to answer the question because I want to move on to the next topic. So I'm going to go on here and quickly broadcast these questions, and then we'll kind of see where we go from there and add some clarity to those answers. Who here has used Poll Everywhere before? Just raise your hand. I'm just kind of curious. 1, 2, 3, kind of under 10. Okay, so it's a really cool tool that we can use in the classroom. So if you teach like a high school class or want to do a classroom assessment technique, it does a pretty good job of being able to do those things in the classroom. Okay, it's taking its time. All right. So it should be live on your phone now. It should be broadcast if you went to my website. If you didn't get that, it's actually listed up top. Or if you want to text me your answer, that's fine too. Okay? And you can see it tallies your numbers in the bottom. So I'll give you guys about a minute to do this. So the question is, which of the following is the correct statistic for the prevalence rate of severe post-operative pain? get you in attendance, too, for this. Does that look right? All right, so let's take a look here and see what everybody said. So let's take a look at our percentages. So it looks like about 48% of you guys said 52%, whereas some said 75, and the lowest said 25. So let's take a look what the right answer was, as reported at least by this study. 39%. In fact, that's severe pain. I think some people, when you look at the higher statistics, they actually clump in moderate pain. So this same study explored people who reported moderate and severe pain only. In fact, post-operatively, 75% of the patients looked at the study reported moderate to severe pain, where only 39% reported severe pain. And when we look at our visual analog scales or some of our pain rating assessment tools, we're looking at not the 1 through 3, we're looking at more of those 5 pluses. Okay? Now, everybody perceives pain differently, right? We all have a different threshold of pain. We all have a different tolerance to pain. That's the beauty of pain, right? You have the athlete who's never been hurt before. Maybe a lot of your high school athletic trainers, maybe you've seen that in freshman football, versus that varsity player who's sustained a lot of injuries and kind of knows what to expect. So let's move on to the next question. Approximately how many Americans are suffering from acute and or chronic pain currently, even on a daily basis? Oh, did I broadcast it to you all? No, I did not. Sorry, my apologies for that one. There we go. You should all see that number now. Now, this is important, too, because, even though we deal with the athletic population, they fall into this general population number. And I would expect that our athletes do experience pain differently, but also potentially more frequently because of the inherent risk of injury at sport. When we look at ACL tears alone, I'm back up to 78 already. We look at ACL tears alone, we look at those people having early onset arthritis, they're going to experience pain probably far beyond their athletic career. Well, since you guys all answered pretty quickly, let's just take a look at what everyone said. All right. So we have more people on the bottom end of it and a little bit less on top. It actually looks like a little ramp. Let's see what the answer is. 30%. That one shocked me a little bit because I've seen studies that have actually tried to report a little bit higher, and I've also seen some that reported lower. But the average right there from this study back in 2016, they reported that 30% of Americans experience either acute or chronic pain currently. Now, if you think about it, that's about, in 2014, 2015, we had 319 million people in America, so that's 30% of them. That's quite a few people. It's almost 100 million people experiencing pain on a daily basis, which is still quite a bit of people. Well, how can we manage some of these pain? Let's take a look at modalities. So if you have an athlete with acute pain, what modality, well, maybe it's not listed here, would you prefer to use with your patient? And I think I forgot like the most basic one of ice up there. So that's other. Now, I've given this same poll to college and high school athletic trainers, and it's obvious that we're going to see probably quite a bit difference between the population and with availability of modalities. That's also one of those barriers we talked about previously, is what do you have available? Because if we're expected to alleviate acute, chronic, and post-operative pain, and if we don't have the right tools available to us, how are we supposed to do that effectively? So let's take a look. There's no right answer to this one. It's an eStim talk, so everyone's throwing that on there. So electrical stimulation seems to be everyone's preference, and I'm assuming the ones down in the other is looking at cryotherapy or heat. Or probably not heat for acute pain, but cryotherapy is probably jumping on that one, and massage, about 5%. So it looks like there's a very heavy push towards electrical stimulation. So of electrical stimulation, because I kind of perceive this a little bit, what type of eStim do you like to use? And this is the last question, and we'll get right back into talking about eStim. Do you like TENS? Do you like IFC? High volt stimulation, microcurrent, biphasic, functional electrical stimulation, neuromuscular? Got some people thinking here, like, wow, I just didn't think I'd be answering a quiz today. That's right. And I'm a program director. I think if you don't point to the board at least, or not have a dry erase board back here, it's kind of an odd day. All right, let's take a look. So it looks like interferential current wins that docket. It's a good assumption. I know a lot of individuals use ice and electrical stimulation, specifically interferential current, for a lot of their treatment options. Okay, because it's really easy post exercise to throw that on there. It's 20 minutes long. Okay, but TENS is up there. Biphasic currents are making it up there. Not many people using functional electrical stimulation, and some neuromuscular. So the reason why I do this too is kind of looking at the population that I'm lecturing to. In fact, we're going to talk about TENS, IFC, and high volt pretty well today, because there's a lot of research out there. Some recent meta-analysis actually looked at the results of pain relief of those modalities. So a lot of the recent stuff is on those. So for a majority of people here, their preferential electrical stimulation is going to be a hot topic today, and you're going to learn a little bit more about it. It's nice when we know the population that we're trying to serve and talk to. So based on all these things, I hope you guys can see that pain's a problem. I hope you could see it before you walked in today. But based on those stats and some of these things, I saw it as a problem. So what I sought out to do in this lecture was to look at subjects suffering from acute and post-operative pain and seeing if electrical stimulation in the recovery process actually reduces the amount of pain perceived as compared to either other electrical stimulation or other modalities. So that's my PICO question. In research, we set those up to kind of help answer that clinical question. So let's take a look at eStim. So what are some current problems that we look at eStim? This is kind of a little bit in a nutshell, we're going to talk about this more at the end, but consistency. So as you can see, this one modality has so many varying parameters. And not only that, per type of eStim, there's different parameters per sensory, motor, noxious, and sometimes people get confused of when to use it. In fact, one of the biggest inconsistencies in the literature right now, and kind of being that roadblock for eStim, is the selection of parameters. Okay? Poor evaluation of outcomes. This has not been anything that's been hidden from us, but patient-reported outcome measures. How do we measure pain in progress? Most athletic trainers, we look at they have a goal, reduce pain. But it's not really truly that big of a measurable goal, and how are you going to measure it, and how do you do that? So how do we measure these things? And having actual patient-rated outcome measures that support us objectively instead of a subjective measure of pain. Okay? And if you look at the meta-analyses, there's a lot of them saying poor outcome measures were assessed, therefore high bias and low actual applicability. So that's the problem with some of these researchers as well. And it's a catch-all treatment. I know some of our and I don't throw my preceptors on the bus. I do that, I guess, sometimes. But, I've seen some of them. Their only treatment option is ice and eStim, or it's heat and eStim, and they don't do rehab. They think modalities is rehab, which it's not. Okay, it's an option to kind of build and kind of make your rehab more meaningful, but it's not the catch-all treatment for everything. You can't use cupping on everything. You can't use kinesiotape on everything. They want to tell you you can, but you can't use it on everything. So it's not a catch-all treatment. It has very specific targets. So what are we trying to accomplish? Are we looking at some of our dry needling techniques or electrical acupuncture? This person, their back must really hurt to have that many electrodes on it. This person's getting functional, and they're doing weights while they're getting kind of, maybe it looks like a rush-in or a type of motor stimulation. There's a TENS unit. This person's getting TMS, which is activating certain parts of the brain. It's kind of going transcranial stimulation. And then we have different types of TENS units or ontophoresis units that we can use for delivering medication. I guess my question is, with everything that's out there, what are we trying to accomplish? And what are we trying to do? Because hopefully everybody's going through this process when they're going through the treatment programs, looking at what's the problem, prioritizing problems, goal setting, reviewing the best evidence, which we're doing today, treatment planning, and reevaluate. Because in athletic training, I've heard this word once already today in the talks, we have to be intentional. We just can't do a treatment to do a treatment. We have to know why and what we're trying to accomplish. We just can't throw something on there because we don't know what's going on. So for electrical stimulation, our common indications and uses is pain control, edema reduction, spasm, muscle atrophy. We can also see it for neuromuscular education and wound healing. Most of those, minus the last one, is really us stimulating a nerve. Most of the effects, if not all the effects of e-stim, are secondary to nerve activation unless you're using direct current or a polarizing current or a galvanic current. And today we're going to talk about pain control. That is usually the number one thing. And when we learn in the basics of rehab, the first step of rehab is reduce pain. And this can assist with it. So in a nutshell, electrical stimulation does have its uses. In fact, it's used for sensory, motor, and noxious stimulation. I don't probably think many people use noxious electrical stimulation around here. One person does, maybe a few people may. But the nerve stimulated influences the pain relief. So this is kind of, I derived this from a couple different sources and looked at how do we do different types of pain relief. And we look at the gate mechanism. Melzack and Wall proposed this years ago. We want to activate those sensory fibers. And there's a very particular frequency and pulse duration or phase duration we use to elicit those effects that are listed above. These are the theoretical foundations and parameters to your practice. So primarily, if you want to activate those, we're going to look at those parameters. Looking at more emotional responses or serotonin or other things of that nature, of the central biasing, we can look at high-frequency noxious stimulation. It's very intense. It's painful. Okay? And then that phase duration / pulse duration you can see is long. It's 1,000 microseconds. And if you're not familiar with that, that's the on time of the stimulation. And the longer it is, you can activate those deeper, smaller nerves. Okay, so you may not want to use 1,000 for sensory, but you could get a sensory-only phenomenon with that and be okay. You can release endorphins. So we're looking at a rhythmic contraction. We want to get the motor, but also the A-delta fiber, which is a nociceptor. If we don't get that, we will not get our endorphogenic release, and that's usually used more for chronic pain, not acute pain. So let's look at some of the evidence behind the practice. So what this section is going to go through is I'm going to kind of list some of the major, like the meta-analysis and other topics, and we're going to go through the articles themselves and kind of look at the stats and see if e-stim works. So one of the very first ones I want to kind of bring up, just because it was back in 2015, it was a systematic review on lateral ankle sprains. We see these quite often. In fact, it's the most common injury in athletics. And I guarantee everybody here this year is going to have a multitude of these. And e-stim is a choice modality for this injury. So out of Virginia, the cast of crew over there, Feger et al., looked at, does e-stim work to improve function and reduce pain in individuals suffering from an ankle sprain? So this is kind of the excerpt from their actual paper. It's really hard to see, I guess, but if you look at the groupings, you can kind of see, you may not be able to see, but on my presentation you'll be able to get it. You look at neuromuscular stimulation, you look at submotor. Primarily high volt is what popped up on their study. High volt had a lot of conventional treatments here. And if you look, they list their treatment protocols and what these studies investigated in terms of the frequency, the duration. And if you actually, I know you can't really see it because it's very small, one thing you're going to notice is a high amount of variability in parameters. Very inconsistent. There are some studies that are using very high frequency, some that are using a very low frequency. There are some that are barely getting a sensory phenomenon and some getting a complete motor response. Of these major, there's only 4 of them listed here that they had, and they only drew 5 for this. They really only saw consistent parameters between 2 of them. In fact, that was one of their limitations, and one of their discussion points was, if we know e-stim works this way at these parameters, why are we doing it these other ways? There really isn't a high consistency in how we're doing these parameters. And in fact, this is their Pedro score of the ones they reviewed, and this is a way to kind of quantify the evidence to see how high quality it is, and these are all going over 7 out of 10, which is a really good number to have for research studies and controlled trials. So we have high quality evidence that's showing inconsistent parameters. And that can be a little dangerous at times when it comes to therapeutic modalities, because consistency is key. We need to be able to, as clinicians, actually know what parameters we're going to use that are going to satisfy our goals. And if I look at this study, you don't really get that and gather that information for consistency. Another study that's kind of in response to this, actually uses the same studies, is another analysis, a curricular based paper on metal ankle sprains, and its title is pretty clear. The current evidence does not support the use of electrical stimulation to decrease pain. Both of these studies looked at different parts of all 4 of those trials and came to the same conclusion, that electrical stimulation was not supported in the use for pain and edema and improved function following little ankle sprain. Now, one thing I'm going to kind of give you a disclaimer, because you're probably all thinking, man, these are 2 really good studies. A lot of these studies used e-stim alone. Okay, there has been studies that showed that e-stim alone as compared to a control and sham isn't necessarily the best, but when used with ice or heat, it actually works better. There are those trials out there. So that was one of the limitations, was this, we were looking at only trials that looked at e-stim and electrical stimulation alone. And I don't know how many people use it minus Russian or neuromuscular reeducation by itself without adjuvant. I know I don't use that. I use it with something. If we're going to do electrical stimulation for 20 minutes, you might as well get an ice or a heat pack on there and get those effects too. So this trial, this meta-analysis and systematic review was very important because it kind of helped demonstrate and kind of illustrate back in 2015 that there was a gap in knowledge, especially when it comes to some of that acute pain. And I don't know if anyone's here kind of aware of the times, but you've noticed probably in the last decade, opioid use has gone up. Pain control methods have gone up. In fact, there was a recent article posted yesterday on the increase of suicide rates. And we only have pain as a mental and physical component. I wouldn't be surprised if it contributed to it. And right now we have very little evidence for that. So, everyone's favorite Cochrane review. So they looked at transcutaneous electric nervous stimulation for acute pain. This is kind of a lot of doctors' gold standards. They go to these, they fall back to these when it comes to prescribing treatments for patients. What's a viable option for pain relief? So let's take a look at this. This is a huge systematic review that does a meta-analysis on things that can, if they have like populations. Okay, it used 19 randomized controlled trials that involved over 1,300 patients, which is a good number to have. In fact, TENS demonstrated greater than or equal to 50% in reduction of pain as compared to the placebo. That's a good metric to have, right? If TENS works, it's decreasing pain. Okay? And they were able to pool some of that data, and that's what they got from it, is some of the studies were able to be pooled because the populations or the samples used were kind of similar. Okay? However, they ultimately concluded that there was a lot of poor sample sizes, and there was a high level of bias. And that's not a good conclusion to have. You have a modality here in pooled trials that reduces pain by 50%, and then we find out that all these studies have a high level of bias and also have poor sample sizes individually to really make those inferences. So it suggested that we need higher quality evidence to continue due to the cost in self-administration. We should use it, though, because it's cheap. It's athletes. You can give it to athletes at home. You set the parameters, you lock it up, and you can give them the consistent parameters. I mean, you can go to Walmart now and buy a Advil or a Aleve TENS unit for like $50. And I know for myself, if you get the Intellect ones, you can get them pretty cheap as well. So they want to continue as adjuvant therapy with other modalities, but not by itself, because the high enough evidence is not there, the quality evidence isn't there to support its use. So that's a huge hit for e-stim, was when the Cochrane review doesn't necessarily support it. Okay? If you do use it, it recommends a strong, non-painful stimulus for pain relief. So have you guys used that cue before, strong but not uncomfortable? Or strong but tolerable, I don't want it to hurt? You guys probably have used that cue. They want it to be strong and sensory, not motor, for acute pain. So another trial. This one fascinated me. I didn't actually, until I started researching this topic, this one never popped up on my search engine until mystically it did. It's quite an interesting trial. this is the clinical practice guidelines released by the American Pain Society. That's a pretty big name, and they collaborated with almost double-digit associations to formulate these treatment guidelines for pain. Back in 2016, they reviewed different multimodal approaches for analgesia, such as opioids, NSAIDs, cognitive modalities such as therapy, counseling, okay, and then physical modalities, acupuncture, TENS, massage, heat, cold. They reviewed it all and made about 13 recommendations. And physical modalities were only 2 of those. These recommendations indicated that TENS was a viable option to reduce pain. However, and this is, I always like when they put however, they ultimately deemed it was a weak recommendation and should only be used as an adjuvant because there's insufficient evidence to support its use. Does that recommendation sound familiar? Okay, the strongest recommendations for pain relief is from opioids or other prescription drugs in a kind of multifaceted approach. Okay, I'm thinking as athletic trainers, we want to find an alternative to opioids. We want to find an alternative to muscle relaxants and pain relievers, right? We want our kids to be drug-free. And to find that TENS and some of these other modalities don't really kind of hit that up very well, that's kind of discouraging. So again, that was from the American Pain Society. And here is the recommendation given. It was to consider TENS as an option. That's not really a strong recommendation. And I even bullet pointed out weak recommendation, moderate quality evidence. And if you look at the bottom statement, the panel can either recommend or discourage acupuncture, massage, or cold therapy as adjuvants to other post-operative pain treatments. So looking back at that poll everywhere I gave you guys, what modality do you use for pain control? We're only weak recommending TENS, and they can't recommend either the other ones that were on there, such as cold, massage, or acupuncture. And this is coming from the American Pain Society. There's a lot of physicians and providers that look to these statements and these organizations to help curb and manage their practice. So kind of moving forward, now we're going to start building a little bit more positive outcomes as we move into 2018. Kazim et al. Looked at the non-invasive treatments for acute, subacute, and chronic pain, looking more at low back pain. Now, everybody suffers from that. I'm pretty sure low back pain is just your youth leaving your body. But no one laughs. It's the last lecture of the day. It's okay. So this looked at the pharmacological versus non-pharmacological interventions, such as acetaminophen, NSAIDs. They looked at it all for pharm. And they looked at exercise, acupuncture, massage, ultrasound, IFC, TENS. They looked at all of these, kind of made a large recommendation and treatment guidelines looking at the non-pharmacologic and pharmacologic interventions, which I think is a really novel idea because that's what we're looking for. It's a fantastic idea. Again, we have one more hit before we get to positive outcomes. TENS, neuromuscular electrical stimulation, in IFC really did not meet that conclusive evidence to be able to be recommended for use, even for chronic pain. Even though we think of TENS, we think of chronic back pain. Low back pain, TENS is the way to go. Okay, and I've seen it work on a lot of people, but it really didn't come up with that conclusion. Why? Their rationale was mixed samples. They had poor measurements of outcomes and lack of patient control and what kind of pain they had. And some places were actually just looking at self-report for pains. They lost connections with those patients, and it just wasn't looking at anything that was really credible. That's discouraging because, again, another practice guidelines for us as clinicians. So the most recent study by Almeida et al. Was a meta-analysis and systematic review. Okay. This investigated IFC versus TENS for both acute and chronic pain. It pooled 8 studies and had a sample size, a total pooled sample of 825 subjects. And it actually concluded, now this is actually a turning for the better because there's been some decent studies kind of in between randomized controls. I'm only focusing on the meta-analysis and systematic reviews because are the highest level of evidence. Okay. But study concluded that TENS and IFC were able to provide significant pain decreases, okay, and positive patient-rated outcome measures. And in fact, there wasn't a difference between interferential current or stimulation in TENS for pain relief. So what does that mean? Both of these modalities by themselves beat out the control, and separately, they had similar pain relieving effects. So that makes IFC and TENS a very viable option for pain relief and interventions for controlling pain and a lot of other things. So again, I like to kind of chunk these out, a lot better visibility, but if you look up here, you can see results per trial, what they concluded for each study, and down here you can see every parameter they used. This is a very well thought out meta-analysis that did its research and did a great job presenting you the information you need to make a really good informed decision on parameters, as well as how it worked for pain relief. And you can kind of see TENS is sitting around for frequency about 100, which if you go back to our original theory, that falls into the sensory range. IFC was the one that kind of threw me off a little bit, because we learned in undergrad, we teach in our professional programs, 80 to 150. That's a textbook answer to what sensory IFC is, right? And I'm sure everybody knows that's the first base setting that comes up on your machine. But if you look at what they were using, they used a 1 to 150 sweep, a 0 to 100 sweep, 20 static, 100 static, and a 50 to 100 sweep. And when you look and read this trial, you're like, wait a second, that's really confusing. That's a lot of numbers. Okay? What they concluded it has nothing to do at times of what exact frequency you use, but what they noticed was the stimulation level. If it was strong but not uncomfortable, if you got a strong sensory phenomenon and absence of a motor contraction, you got adequate pain relief. Now that is something that's interesting, because if we look back even to basic theory, we can use a lot of these waveforms to activate a motor or noxious pain. But when you look at the order of activation of nerves, sensory is always first, which means if we have adequate enough stimulation to activate those nerves, but yet not get a motor contraction, our parameters kind of sometimes aren't necessarily should be focused on. It's that stimulation level. It's strong but uncomfortable, and it's not causing pain. It's not causing a contraction. It's causing a strong stimulation, which I think is interesting. Students ask me all the time, we have all these parameters, which ones do we use? Which one causes a strong sensory phenomenon and causes pain relief? That's what the trials and studies are saying. So I know everybody loves forest plots, so I thought I'd throw one up here. As you can see here, this is just looking at the comparison of IFC and TENS. And basically, if you look at this, if it's on the left side of that, it supports TENS, and the right side, it supports interferential current. And so in a meta-analysis, they pool everything together, and they find their confidence intervals. They see, if it crosses that baseline, if it's one favored versus another one. And as you can see, about that big black diamond on the bottom, it kind of, the mean favors IFC, but the confidence interval goes into the TENS side, which means both treatments are viable options. There's no difference between the treatments. But remember, this study showed there was a difference between pain relief with TENS and no TENS or no E-stim and IFC in a control group, which means both of these are viable options for pain relief. And that's what I want you guys to hear, is that there's hope when it comes to pain relief. As you can see, the p-value was not significant, which means that's what we're looking for. We don't want it to be significant. Okay. We're going to go through one more trial and a couple other notable ones and kind of conclude with best practices. So here's another one. Now, not a lot of people here manage total knees, but there's a lot of studies on pain relief in total knees that jump into the post-operative pain relief. So what they looked at was TENS, neuromuscular electrical stimulation, as well as electrical acupuncture for pain relief, for post-operative pain and pain management. Okay, so again, here's their things. They did a great job listing their parameters. Okay, but here's the nutshell. TENS reduced post-operative pain with the following parameters. An intensity of 15 to 40, or strong but uncomfortable, and a frequency, as you can see, between 70 and 150. They actually saw some reduction of pain with electrical acupuncture, and there's the parameters for that. And neuromuscular electrical stimulation actually, and this is kind of a sidebar because it looked at strength too, increased function and strength in individuals with TKA. And there's the parameters for that. And those are all great things to know, is what parameters can we use that have evidence base behind it to support our actual treatment goals. And this study did a great job putting it all together for you. And as you can see, they're all recent ones, 2018. So other notable references that I want to kind of throw out there before we jump into the best practice guidelines is in 2017, there was another total knee study that showed that TENS post-op actually reduced the need for opioids. Now that's where I think the magic's at right there in research, right? If we can reduce pain well enough that we don't have to use things to mitigate severe pain, that's the magic right there. And opioid abuse is a problem. In 2014, there were 245 million prescriptions for opioids prescribed. There's 319 million people in the United States that year. 76% of the people in this country, if you gave each of us a prescription, 76% of us would have had one prescription for an opioid that year. That's a daunting number. I hope that's a concerning number. But as you can see, post-operatively, and my wife's an orthopedic PA, so she does knee and shoulder, so what do you think they do? They do these nonstop. And the need to reduce opioids post this surgery is needed. In any surgery. We don't want our athletes drugged up, nor possibly get addicted to these substances. So this study actually showed that there was reduction, not only 12, 24, and 48 hours post-surgery. Again, here's another one in 2010. They used TENS pre-incisional and post-operatively, and again, it showed the reduced need for opioids post-op. And they concluded that 100 hertz or a 2 hertz with a strong sensory stimulus was needed to conclude that. And that was a very good study, as well as a Simpson one. This, if anyone's read this one, this is actually kind of my, I make our students read this one. They actually use TENS for pre-hospital analgesia in the ambulance. Okay, imagine all the pain meds you push in the ambulance. Well, they preset it for the EMTs, and they throw it on at the set parameters that are there, and they use it before they get to the hospital. And guess what? It decreased pain before and at the hospital and anxiety. I'm not going to lie. When you see, you guys have all at some point transferred care to the EMTs. Do you see a look of horror on those kids' face and parents' face when you're putting their kid in the ambulance? So imagine if we have a treatment that can reduce pain, reduce the need for opioids, and decrease anxiety while they're on the way to the hospital. That teddy bear in the ambulance doesn't work. Okay, just throwing it out there. So those are all really interesting and notable references that really show that electrical stimulation does work. Okay, so looking at the parameters, now this comes from a multitude of sources. This is kind of my recommendation based on what I could find. High frequency, low intensity works best for acute and chronic post-operative pain. But low intensity doesn't mean you can't feel it. It means it's a strong sensory phenomenon. High intensity means we're getting a motor contraction or a noxious stimulation. We just want a sensory phenomenon. For IFC, the traditional is 80 to 150, but a lot of our studies use 100. I even found one study that did 80 to 130, which is kind of an odd number. But really around that parameter, right around 100 works best. And high volt. Now high volt, you can't really change the pulse duration, it's preset. But a frequency of 120 in submotor was recommended by a lot of studies for high volt for pain relief. But it's not about the frequency. It's about the intensity. Okay? So clinicians should use 90% of a visible motor contraction. What does that mean? If you ever turn Eastham up, strong but uncomfortable, and all of a sudden you see that muscle start to tense up, once you see that, you've achieved motor threshold. Drop it 10% on the device, so if you're at 90, you drop it 9 amplitude to 81, and now you have a strong sensory phenomenon. Or you can just strong and uncomfortable, go to a motor twitch, and then go the opposite direction until it goes away. That works the same. but you should not have a motor contraction. If you see one, you're not doing it right. Okay, strong but comfortable. That's always something. Comfortable, not uncomfortable, in absence of a motor contraction. So I'm actually I'm getting right on time. Look at that. Concluding statements. So what I want you guys to walk away with is those evidence-based parameters, and looking back at our goals. We presented kind of the evidence behind the practice. We've shown the parameters. But now I want to look at, there's a potential huge benefit to electrical stimulation. As you can see, even the recent trials of 18 and even some of the ones in the past, there is a potential benefit here for using e-stim in the clinic. However, there's also a lot of conflicting data out there. And I like to think of it this way. I heard earlier today that sometimes we're our worst enemy, right? I think when it comes to choosing parameters for modalities, we're our worst enemy. We're looking for the right thing. We're trying to change things up. I've seen clinicians cut electrodes to fit where they need to when you shouldn't touch those that way, because you can impact the actual electrode itself and shock your patient, unless that's your therapeutic goal and get them out of your clinic. I don't know. But we alter things so much that sometimes we're our worst enemy for our treatment outcomes. Okay? Then we got to use our knowledge to better ourselves in the clinic, make the most up-to-date. I'm not telling you go read 11 articles a day for the rest of your career, because I know I can't do that. I can't even get my students to read 1 article per week. How am I supposed to get myself to read 11? Okay? So, try to stay up to date. Come to these things. Even when it comes to modalities, there's so many hot fads and modalities that I fear that sometimes we're losing focus of what the outcome is for patient benefits. Sometimes we look forward and say, okay, cupping is great, and it's going to taper off. Kinesio tapers off. There's some research that comes out. People hold those proprietary names. What we should be focusing on is patient outcomes and getting those patients back safely. Okay? And parameters. It's all about the nerve stimulation. Which nerves are you activating? For sensory and post-operative pain, it's the A beta fiber, the sensory nerve we need to activate. But as a clinician, you have to ask yourself, what tissue am I stimulating, and what am I trying to accomplish? I would hope that we would never live life with no goals, right? But the same thing is when we look at our patient outcomes and our patient rehab plan, what are we trying to accomplish, and does it meet our goals, and does it match what this kid and this athlete needs to get back to activity? And as researchers, we need to really start looking at how can we develop high-quality evidence. I know I was looking at some of the criteria for the Cochrane Review for low bias, and it's like you must have over 200 subjects per treatment arm, and I'm like, whoa, that's a lot of subjects. We're lucky for a lateral ankle sprain study to get 20 people that sustain an ankle sprain in that time period to be able to measure these things. So are we doing ourselves any justice, or what should we do in response to ensure that we're getting the appropriate outcomes and that we're giving the best information out there? Again, I want to thank SPATS for allowing me to present today. And when you guys have my presentation, I have a plethora of sources that I use in the generation of this, and I would welcome any and all questions that you guys may have. Oh, we got one over there. Got the hard one off the spot.
We got questions. Actually, I want to thank you for a very excellent presentation that was well put together and pretty comprehensive. One comment that I would make is less a question and much more of a comment, but be careful of the evidence fallacy. A number of the sources you cited in there talk about there is not sufficient evidence to conclude that this is useful. And where we get in trouble with evidence-based practice is we don't understand that insufficient evidence of an effect is not the same thing as evidence of an insufficient effect. That is, not enough evidence that it works isn't the same as evidence that it doesn't work. And there's a lot of these things that are garbage in, garbage out, and it's hard to get good data with bad studies. So I think that as we see some time and more literature in this area, hopefully that'll help sort itself out.
Yeah. I thought about that too when I was reading that fallacy, the evidence of absence, or the absence of evidence isn't the evidence of absence. And you're right. There's a lot of things out there, and that kind of ultimately concludes is that, we need to get that evidence out there that actually adequately defines whether it works or not, and set ourselves up for success. Everyone's like, social. All right. Well, thank you.
Thank you very much. Okay, just a couple of words about the social tonight. It's at Schlitterbahn. Those of you that have been here the last couple of years already know. Make sure you don't park at the water park. It's at the resort hotel. It's not at the water park. So if you're parking in the water park, you're not going to be anywhere near where you're supposed to be. So make sure you get in the resort. There's some parking right there at the entrance. Usually the parking lot right in front of the lobby is pretty full. So just be aware of that. We'll start serving some food at 7:30, free drinks at 8, and open bar not open bar, cash bar the whole night. So not open bar the whole night. Sorry. We learned our lesson several years ago on that. Okay, some door prizes for those of you that waited around till the end. Some dozen golf balls from Brokerage Store. That's going to go to Wendy Skaberek. No? Next? Oh, she there? Sorry, from Temple. I'm sorry I butchered your last name there. Sea Ranch, $25 gift certificate goes to Brooke Nooper, or Nupin. Is that right? Okay. I've got a fireworks cruise for 2 people. Fireworks cruise for 2 people. Ruth Grasty, Dobie High School. Is she there? Nope. Vanessa Vallejo, Harlandale. Next. Phil Keys. Right in the back. Phil? Where's he at? Okay, there's Phil back there. Paradise. Kayak rental from Paradise. Aaron Moss. Aaron Moss. You look like a kayak kind of guy. Bay fishing for 2 people. Bay fishing for 2 people. Kimber Rogers, Friendship High School. She here? There you are. And if I understand if you're not from here, please try to use these of some way, because our vendors are gracious enough to give those to us. $25 to Whataburger from the brokerage